Everybody. This is the part 2 of the chapter 2. In the previous part 1, we understood that it is very, very important to recognize who are the progressors, which patients would progress. We saw Branholden Vision Institute myopia calculator, and we can calculate on that which patients would progress and which patients may not progress. So it is important to understand that we are into all this to stop the progression and not to give treatment to those who are either not progressing axially or they are not progressing at all. So it is very, very important to keep a very close view of which patients are progressing and which patients are not progressing. We would talk more about which patients are progressing, in terms of glass power, but axial length is not increasing. And in some of the patients where axial length is increasing and glass power is not increasing. I think this particular point we will talk about when we will have one-to-one session on Zoom meeting. For this particular video, we will move forward to the next part of it when you have actually diagnosed that this is a progressor versus a non-progressor. Now, step 4, obviously, from the impact guidelines or even otherwise, would be that once you have the progression, or even before that, when the patient presents to you and you can see that this particular patient is a myope, there is a possibility that this patient may progress. Now, you don't know whether this patient would actually progress or will not progress. And so, therefore, you would start them straight away on environmental modifications, which are mainly to reduce the near work and increase the outdoor activity. Now, both the things go hand in hand, but reduce near work typically means that you have to reduce the near work, which is more closer than 25 to 30 centimeters and at a stretch. So both the things are very, very important. There have been multiple documented works where they have suggested that it is actually the near work and prolonged near work which predisposes the patient to myopia and myopic progression. So these two things are important. We have to see that they are not doing a lot of near work at a stretch. Also, they are not very close to the eyes, which means that not closer than 25 to 30 centimeters. Now, there's a device which is known as Cloud Clip, which can do this for you, but the cost is around 16 to 20,000. Not available in India. You can outsource or take it from China, but for each patient, you would need that device. So what we can also do is we can take the device, give it to the patient just to make sure that they are not doing excessive near work, and then tell them that you are really doing a lot of near work and you should avoid this. It has a built-in software and you can actually see how it is working when you have the report after 1 month. The second important point is to sit outdoors. Now, way back, a few years back, or even 8 to 10 years back, there used to be still some of the patients would say that when you walk on the grass, your power may actually reduce. Now, this actually comes from the fact that when you don't sit indoors, there is a possibility that your power may not actually increase, and there are some articles which do suggest that it is actually the outdoor sitting which is more important than near work, and there are other articles that near work is more important than outdoor activity. Regardless, both the activities will work. You have to sit outdoors as much as possible. Typically you should be having sunlight, but even if you sit outdoors, it would work. Now, vitamin D3, the curious case of vitamin D3 is that whether it is related with the outdoor activity that patients are or children are having documented evidence that myopia works closely with vitamin D levels going down. But then those are the same patients who do not go outdoor, and so they do have vitamin D3 deficiency. So I would not say that vitamin D3 is directly linked with myopia progression, but yes, you can definitely go ahead and get serum vitamin D3 done, or you can empirically give them a low dose vitamin D3. Like nowadays they have come up with specific tablets which have a very small dose of 800 international unit. So vitamin D3, the dose is 60,000 international unit, 4 doses every 6 months. Now, giving a subnormal or low vitamin D3 dosage would be an empirical treatment, and you never know what you are doing. Regardless, if you want, you can still do that. A good idea would be to do serum vitamin D3 in patients and find out not only for myopia but even otherwise. Low concentration atropine eye drops starting from 0.01% to 0.02% to 0.05%, atom 1, atom 2, lamp 1, 2, 3, and atom 3 studies on pre-myopia. This can go on and on. So low concentration atropine would be a separate topic, and we would cover it extensively. The other option is peripheral defocus lenses, which nowadays there are three major brands which are available, starting from Hoya, Myosmart, to Essilor, Stilest, and Zeiss with their Care lenses. These are peripheral defocus lenses. In the part 3 of our first chapter, we did saw what is the mechanism of peripheral defocus and what is the peripheral hyperopia and how does it predisposes to myopic progression. So there will be a separate talk on optical options, which would include all the defocus lenses and newer lenses which are also available. Orthokeratology and red light therapy will also be covered. These are two things which are not really prevalent at this point of time in the country. Good options, little bit expensive, but they are options which at this point of time in our clinic we reserve them if patient is increasing despite using low concentration atropine peripheral defocus lenses and a combination of both. So the follow-up is very, very important. You have to closely monitor them. You have to see, first of all, if you give drops, you have to follow them up very quickly, very closely. First week, first month, 3 months, 6 months. Some measurements you have to take, like axial length keratometric refraction 6 monthly. If there are no complaints, pupil size is equally important if you are giving atropine. Reassess the progression, redecide the target. It is very closely, very similar to glaucoma, where you keep on changing your protocol depending on how much is the progression and how patient is improving in terms of no progression. So tapering and cessation of myopia control treatment, the total duration of treatment, should it be 2 years? Why 2 years? Now this at this point of time I would really like to tell you that 2 years for atropine traditionally comes from bulk of the studies which were done for 2 years. Now, if you go back to atropine, so if you give glasses, there is no 2 year limit. Only this 2 year limit is when you are giving at low concentration atropine eye drops. Now, when you are giving low concentration atropine eye drops, the typical studies which come to our mind is Atom 1, which was published by Singapore by Donald Tan and Audrey Chia and co-workers. This was published way back in 2006, 2007, and what Atom 1 was done, Atom 1 was a unique study. Now, this study was done on 400 Singapore children and they used 1% atropine, which was randomized between the two eyes. Now, it was actually thought to be for 2 years only. And from there, I think this 2 years has got stuck. We did our first study on atropine and we presented it in 2018. And we did it for 3 years. That was an RCT between placebo and low concentration atropine, and we had patients where we put the drops for 3 years, and now we have the data where some of the children where we stopped the drops after 3 years and restarted them, and there are children who are using low concentration atropine for almost 4 years and 4.5 years. So we have to see the rebound when the patient comes back to us of these various treatment options, because rebound is real, and a lot of time it happens more if you are using a higher concentration atropine. How long the treatment can be continued? Well, it can be continued till the age at which there is no further progression. So that is very, very important to understand how long the treatment will be. Now, I just missed out on this particular slide. There are some investigations which we do in our clinic, and we did touch upon the basic investigations in step 2 of diagnosis and analysis, but we did not touch upon an important investigation, which is binocular examination, near point of convergence, near point of accommodation, pupil size, and accommodative lag. Now, these are some of the tests which are commonly done in orthoptic clinics and optometry clinic. But remember, when you are using or when you are planning to use low concentration atropine, you should be aware of accommodative lag, which is commonly done with monocular estimation method. Now, this is a very easy test. What you do is you give patient glasses. So when the patient has come first time to your clinic, you cannot do accommodative lag. You have to do a cycloplegic refraction. call the patient with glasses after a month or 2 months or 3 months, whatever is your time interval that you call. And then if there is a progression, or even if there is no progression, you can easily do an accommodative lag. Now, by accommodative lag, what we mean is that when patient is looking at a distance of 25 centimeters, or say suppose he's looking at a distance of 67 centimeters, he should be using an accommodation of 1.5 diopters. Now, when you check it, if there is a lag of accommodation, you will not see that you will see a small plus power or a small width movement even when he's fixing at 67 centimeters with glasses. This particular lag of accommodation, so patient should be, when you do a retinoscopy at a distance of 67 centimeter, patient is using his full correction, what should be the movement of your retinoscopy streak? It should be a zero movement. There should not be a with or against movement. So if there is a with movement, what it means is there is a lag of accommodation. Patient is still not accommodating as much as the patient should be. And if the movement is on the negative side, this is known as lead of accommodation, which means patient is accommodating excessively. Now, typically the thought process would be that if there is a lead of accommodation, atropine would actually work only when there is a lead of accommodation and not when there is a lag of accommodation. However, most of the studies have suggested that there is normally accommodative lag in all the patients who are progressing in myopia, and atropine works well even in these particular patients, therefore suggesting that atropine has an alternative mechanism of stopping the progression of myopia and not working on accommodative lag. Devanshi and me, we did some work on this, and we found that atropine 0.01% or even 0.05% does not change accommodative lag by a very high power. Even after putting it for a month or two, we followed up the patients and we found that accommodative lag is not really influenced hugely by 0.01%. Rather, with 0.01%, there was no effect on accommodative lag, and with 0.05%, I think there was a small difference of 0.25 diopters. So accommodative lag was still there even with or without using low concentration atropine. Pupil size, yes, most of the patients or bulk of the patients, there will be an increase in pupil size when you use atropine. Does it cause photophobia? In cases of 0.01%, the pupil constricts easily, significantly in light, and so most of the patients don't complain. But yes, with higher powers, there is a chance, there are set of patients, so we peg it to almost like 1 out of 10 or almost 10% of the patients, when you use higher concentration atropine, do complain of change in pupillary size. Regardless, we have to take a baseline pupillary size, baseline accommodative lag, and a baseline binocular examination whether patient had an esophoria or exophoria, and this has to be evaluated after giving glasses so that there is no new problem which occurs because of our intervention to control the progression of myopia. Near point of convergence, near point of accommodation, these are two separate things measured with RAF ruler or Green's ruler or Prince rule. You can use it with a common RAF ruler which is available in the country, very easily available. You can do a near point of convergence where you have to show them a line, and they have to, you bring the line closer, and at the point where you see that the line has doubled, there you have, that is where the break has occurred. You go back and find out what was the point at which it broke. Near point of accommodation, you show them letters and it is monoocular, and NPC is binocular. So a near point of accommodation, you can bring the object closer and see at the point where it get blurred is near point of accommodation. Shermer test, mainly because you are going to put the drops for a very long time, so it is not really mandatory, but it is an optional test. You can do a Shermer test just to be sure that the drops, and so some of the low concentration atropine drops are now BAK free, but others are still with BAK, and they may create a problem with dryness of the eye because you are going to use the drops over a very long time. Vitamin D3, serum vitamin D3 level, you can get it done. It is also not mandatory because at this point of time we are still debating whether it is vitamin D which is the cause for myopia progression. So you can do it if patient is free to happy to get it done, you can do it. Topography, keratometry is sufficient, but a topography would be a better approach because normally keratometry would only objectively evaluate the central 2 millimeters of the cornea, and topography will give you a larger picture and will obviously be able to tell if there is some progression, not at all in the center, but even if in slight paracentral area. Aberrometry again not mandatory, but once we are giving low concentration atropine, we should be sure that it is not creating any havoc in the aberration profile. We did some study, we presented it in AIOS and published it in IGO, suggesting that low concentration atropine does not affect accommodative lag, does not really affect NPC, NPA, and does not really affect binocular examinations and aberration profile of patients. Choroidal thickness, so there has been some work on this really in the nascent stage starting from 2016. But the problem with choroidal thickness is that at this point of time, the imaging modalities which are available are not able to capture in in real sense the true choroidal thickness. But it is known that choroidal thickness does decrease as the myopia progresses, and so they have also suggested that choroidal thickness is also inversely proportional to the myopic progression. OCT macula you can do because myopes do tend to go towards maculopathy. Central point thickness in the macula can be done, but again it is optional. So bulk of these tests are not really should be done in all the patients, but can be done if you are practicing purely myopia and if you have got the instrumentations. So you can do it. It is not mandatory. It is more like based on exploratory and research purpose, but you can do it in your clinic. Now, who is exactly a progressor? A progressor versus a non-progressor. We already took this up, but there have been multiple articles, and multiple articles have defined it in a multiple way. There are no gross articles from India, but they would come. So in terms of power, it is minus 0.5 over a year. In terms of axial length, 0.2 millimeter over a year for children above 14 years, and 0.3 millimeter over a year for children above 14 years of age. And so that is how they define myopia axial length progression. Point 2 is the cutoff at this point of time. This is from some of the articles, but it is the 0.2 millimeter which is the cutoff currently. No changes in ocular biometrics, otherwise no change in keratometry. The key obviously is progression. And so what are the recommendations for intervention? So if there is a pre-myope who is a non-progressor, you just have to tell them environmental activities as we saw in step 4 and 5 of impact guidelines. So this is all a repetition of what we have already discussed, but yes, it is very important. You have to see pre-myopes who are a non-progressor more than 2 hours outdoor time, reduced time on near-based activities. So basically it is the environmental modification which we are talking about. Pre-myopes who is a progressor, so there is a reduction in hyperopic reserve and axial length is also progressing. This would certainly need some myopia management strategy. You have to talk with the patient. Glasses are definitely an option because the compliance is almost 100% with glasses. If you are wearing the glasses, definitely they are working for that. You can look for associated risk factors, and we did some study on low concentration atropine for these pre-myopes, and in our clinic we found that it was definitely an important parameter where it reduced the progression in these pre-myopes. Myopic progressor, you have to do a peripheral refraction, do an accommodative lag, behavioral modifications, and then go to either myopia control glasses or low concentration atropine. And in reserve, we keep ortho K and red light therapy. So now for diagnosis, there are various new biometers. So biometry is basically what? It will give you the corneal curvature, which is the keratometry, and it will give you axial length. However, they for the sake of for the sake of improving the practice in myopia, there are certain new biometers like Oculus, which has done a tie-up with BHVI, and what they have done is they would give you measurement of axial length, measurement of keratometry. They would do certain data analysis based specifically on BHVI, which is free online. Then they will give you risk classification. As we saw in the BHVI calculator, they will give you the second part, which is the axial length progression, and the third part, which is what is the risk of progression, pre-myope or myope. And then They will give you a PDF of this particular myopia report and finally the growth analysis, and they would also suggest what are the options. This is a wonderful tool. Only thing is, all this can be done with a biometer. You can put it in BHVI. Yes, it would need integration. They have done the integration for you. The asking price for this is typically in on the north of 30 lakhs. So that is little bit on the higher side. But I think they would they quote around 30, 32, but they it should be around 25. Another optical biometer which will come up, I think it has come up, is optical biometer by Pristine, newer company, Bangalore-based company, Indian company. They will give you these 12 parameters. And I was talking with Anand, who's the lead researcher for this particular machine. They do give you axial length upon corneal radius ratio also. Uh, they would give you all these parameters, but typically not a real risk factor analysis at this point of time, not a myopia report at this point of time. That would come in future. Yeah. So this is another machine which has come up by Topcon. The only thing which differs here is that they would give you a differential assessment tool option where you can see over a period of time what is the how your myopia management is progressing, what are the typical growth curves for that particular age, what is the treatment you have given, data part, and also a Placido topography, not linked with BHI. They have their own growth curves, but yes, there is a there's a structured pattern where you can actually find out how much your axial length is and what are the trends. So BHVI, you are putting a single value. Here you are putting values over a period of time, and it is generating the graph for that particular patient. Similar to the Excel sheet which I showed you, you can take those points from Excel sheet and create your own growth trend, and you can also put whatever you want to put in that growth chart and show it to the patient. Now, this would be a separate lecture. I can, regardless, take it at this point of time a little bit on low concentration atropine. At this point of time, we do use it as a first line, mainly because of the cost. But two things are important. You have to do accommodative lag and near point of accommodation before you start this patient. You have to put it once a day at night, call the patient again after a week, again after a month, again after 3 months, and again after 6 months. What are they doing? Whether they are progressing or not. If they are progressing, recheck the axial length. Progression, sometimes what happens is that the progression may slow down but not obliterate completely. At this point of time, we have seen that twice a day works better than once a day. So for us, if the progression is real quick, we will start low concentration atropine twice a day in the first instant itself. I would be talking about it later in a separate lecture. And then if it is not responding, we are giving atropine 0.05%, which will come up in the market in couple of months by Antod and by Sun Pharma. So this is how you have to follow up. As I already said, you have to do the compliance check. That is very, very important. Accommodative lag, pupil size, visual acuity, cover test, near point of accommodation, near point of convergence. All of these things go with atropine. Follow up after 1 week, 1 month, 3 months, and at 6 months. And then there are peripheral defocus lenses. The three companies, importantly, Myosmart, Essilor, and Zeiss, and Dots by Essilor diffusion optics technology, which is not currently available in the market, and I think it will come up later once these. So all the lenses do work. There is nothing like that this particular lens works better than another lens. In our practice, we have seen that all the three lenses work. If you tell me about the success ratio, almost 90% of the patients do have myopia slow down by 60 to 70%. But there are few patients who do progress despite using glasses, and you can add atropine. Bulk of our patients are on combination therapy, and once both of them are not working, we switch over to orthokeratology. So this is typically a follow-up schedule and evaluation for peripheral defocus lenses. Much easier compared to atropine, much expensive compared to atropine. You have to call them after a month if there is any difficulty in visual field, because it basically blocks the apart from central 25 to 30 degrees, it will block the peripheral rays to focus on the retina, and it will make them focus just prior to retina, so it reduces the peripheral hyperopic defocus. If there are any complaints, try to look at the fittings. So basically it is the fitting problem, because it is very similar to progressive lenses. Again, call them after 6 months and do all the tests that we thought of before that. So this is the final sheet of myopia management guideline. This is the summary of what we talked about in this particular talk. History. You have to look at the history. Younger age, parental myopia, age, ethnicity. I can take a screenshot of this and post it in the group at the end of once we have finished this, and we can discuss this particular slide in our Zoom meeting, apart from discussing other things also. Evaluation, categorization, whether the patient is pre-myope or a myope, and whether he is a progressor or not. And you have to suggest behavioral recommendation in the first visit itself. Once the patient presents to you and the patient is a myope, you have to give them behavioral recommendation right at the first meeting. So that is your meeting at which you have to tell them that this particular child may progress, regardless he progresses or not. And if he doesn't progress, it is very important to tell them that it was probably due to behavioral recommendations and that the kid is following. And if he has not progressed at this point of time, there is always a risk of progression once the height increases, or prepubertal or post-puberty, or once he reaches to standard 9, 10, 11th and 12th, where they start going more for academics and less for outdoor activities. So do a closer follow-up. If you feel that the child is going to progress quickly, once you give atropine, you call them after a week, first follow-up after a month, and later follow-ups can be based depending on the progression. At 6 months, you have to just evaluate the myopia progression, make myopia sheets as a priority, make growth trends. If you don't have hi-fi machines, you can make your own growth trends on the Excel sheet, and it is very easy. It is not that it is difficult. It takes the same amount of time as much as the fancy equipment does. So don't get bogged down that you don't have a fancy equipment and so you cannot show a trend or show that. You can easily go to the website of BHVI, download the growth trend chart for the patient in the first visit, and rest of them you can do it in your own clinic based on Excel sheet. You go on the chart and it will draw a very good line diagram for you. So thank you so much for this particular for joining the course first of all. And for the second part, we would have a Zoom meeting on Wednesday, and I will post the link and I will keep you posted. I will send you this sheets, screenshot of this particular slide, and more articles, more literature on axial length upon CR ratio, which is also becoming more and more important as the time is going on. So thank you and have a great weekend.